second in the Cancer Survivorship ECHO Series. Tonight we are talking about cancer distress.
You want me to get off speaker?
Yes.
Yeah.
And Tracy, I might want to have you mute everybody until we do roll call. That's probably a good idea. So sorry about that. So thank you again for joining us tonight. We will go through a little bit of kind of housekeeping in case some of you haven't joined an ECHO before. This is a Project ECHO where tonight we will cover information and didactic about psychosocial distress, and then we'll go a little deeper into a couple cases, and we hope to instill some great discussion, so you all are welcome to be part of that conversation, and we'll show you a little bit in the next few slides of how to do that. So let's go ahead and go forward. So our agenda for tonight will be, we'll do some introductions, and part of what we want to do, because we do have a lot of you on the phone and on Zoom where we can actually see you and some we can't. So we're going to do some check-ins, go through some housekeeping, and then we'll introduce our experts as well, and then go through the case presentations and wrap up. So this will be our kind of plan for the evening. All right. And for some reason, I'm going a little slow. This is our continuing education statement. So you will get continuing education credits, both nursing, physician, or other types of certification, depending on what your discipline is. In light of that, we have to go through a few disclosures. Pretty much everyone on the panel, except for myself, have no disclosures, and my disclosures are on the slide, where I do work with a few industry partners. This is your activity. So for getting your continuing education, it's 81 pages. As you can see, there's several ways to get your continuing education credits. You can either text in, you can log on to the website, or you can use the mobile app. But it's 81 pages, and you will get one seat for this activity, and we will repeat that at the end of our wrap-up as well. We are supported by a generous grant from the Centers for Disease Control through the Kansas Department of Health and Environment, and supported by KU Cancer Center and the Masonic Cancer Alliance. So we do want to acknowledge our funders, and without this type of support, we could not do this type of activity. So thank you. And now on to our check-in. So we are going to stop sharing the slides and look at all of you, and you can see us. And we'll start here with our team that's in front of you. And we will kind of show you a quick way to introduce yourself. And if you want to share anything, share where you're from, please go ahead and do that. So we'll start with Dr. Nye, who's now becoming a seasoned ECHO regular.
Hi, I'm Lauren Nye. I'm a breast medical oncologist at the KU Cancer Center, specializing in breast oncology as well as high-risk breast clinics.
And I'm Jennifer Klimp. I know a lot of you on there. I think I pretty much know all of you. I'm the Director of Cancer Survivorship here at the University of Kansas Cancer Center and the Director of this ECHO Series.
Hi, I'm Claire Anderson-Sante, if you want to be fancy. Saint is fine. I'm the Program Director at Gilda's Club Kansas City, which is a local nonprofit serving our cancer community, and happy to be here.
Hi, I'm Trish Long, Navigation Services Director at Masonic Cancer Alliance.
Great. And then I think we'll have Dr. Hamilton chime in as part of the faculty. And if you want to introduce yourself, Dr. Hamilton, that would be great.
Dr. Hamilton, Jessica, I'm one of the clinical psychologists that works over at the Cancer Center. I'm the Director of Psychodiagnostic Evaluations from Medical Interventions. Can you hear me?
We can. Yeah, if you can go a smidge louder, that'd be great. But she said she's the director of lots of things and has built our distress protocol. She's our go-to psychologist, and we are super excited that she's joining us tonight. Great. All right. And then Tracy, part of the ECHO team here at KU.
Hi, everyone. This is Tracy McCarty. I am your program contact for the Cancer Survivorship ECHO Series. So if there's anything you need, please don't hesitate to get in touch with me.
And Tracy's in the background all the time, so please don't hesitate. If you have a question, if you need some help, don't hesitate to do that. We also, as you can see, we're going to go around and introduce the rest of us real quick, but you see in the chat box, there's a little orange box with some numbers in it already. Feel free to click on that. You can see any dialogue. And that's another way where we do want all of you to go ahead and type your name in so that we know that you are here today. And the important part is some of you, there's several of you in the room together. This is a good way that we know who's in the room, and we can count all of you as participating. So I think we'll start with Selina, since you guys are also going to be presenting a case tonight. So if you want to introduce yourselves and just show us who's there, or go ahead and type that in the chat box. You may still be muted. All right. I think you are, Selina, you are still muted. Here we go. Well, we know Stephanie's there and Melanie.
I'm here.
And
can you hear me?
Now I can hear you.
Okay.
There you go.
I'm Stephanie.
Perfect.
I'm the social worker here at Tammy Walker Cancer Center in Salina. And I have with me Melinda, who is a student that's with me this year.
Great.
Social work student.
Very nice. Well, thank you guys for joining. All right. And let's go ahead to, is anyone from Lawrence Memorial on? All right. Lawrence Memorial? No? All right. Well, if you are and you are unable to unmute, just go ahead and type that in the box. Hayes Med, we saw a couple folks from Hayes Med on. I think Denise, are you out there?
Hi, I'm Denise DeBoer. I'm a nurse practitioner here at the Hayes Med campus, and then I got Caitlin, nurse navigator here at Hayes as well.
Yes, great to see you guys. All right, how about anyone from Olathe? I think I saw Terry Kopecki. Are you out there?
Yes, this is Carrie Kipke from Olathe.
All right, anyone else with you, or anyone else from Olathe?
Carla Estronix in her office online too.
Hi.
Hey, good to see you.
Olathe Cancer Care.
Awesome. Anyone from North Kansas City? Susan, maybe? Yeah.
And Tanya Yates.
And Tanya.
Yeah, she's
Susan and Tanya. All right. It may be a little hard to, I know unmute sometimes is a little challenging.
Jody Barr just joined from Lawrence.
And Dr. Barr just joined from Lawrence. Let's see, do we see her smiling face today?
Not yet.
Not yet. We'll hopefully see everyone's face tonight. We'd love to see
I'm
you
sorry,
all.
this is Jody. We have new technology, so we're trying to figure it out.
No worries. Well, good to hear you. We always love having you join us.
So it looks like with Dr. Barr, there's Amy and Liv Frost.
Great. Good to see you guys, because I'm visualizing you. All right. Coleman, great, Kansas and Western Missouri.
It's me, Carol Bush from Wichita.
Great. Thanks, Carol. How about Truman Medical Center?
Hi, it's Deneen Jones from Truman Medical Center. I'm here.
Hi, Deneen. Great. Thanks for joining tonight. All right. And then KU Health System. I know we may have sort of a smattering of folks from different places. So if you are affiliated with the University of Kansas Cancer Center or the health system, please go ahead and chime in and say hi.
Hi, this is Michelle Fauché, Radiation Oncology. I am a research nurse.
Great. Hi, Michelle.
Hi.
All right. Anyone else?
Oh, she's not the health.
All right.
And it looks like Dia Arier from St. Francis joined us.
Great. I love that we have this team here because there's a lot of you out there tonight. So I love that we have a tag team here. All right, and that was from St. Francis. Great. And then anyone else from KU, the health system? I think I saw Treza's name pop up. Treza, do you want to introduce yourself? Say hi. A research scientist, and she works in tobacco, and they'll be joining us in 2 echoes from now. So, Treza, thank you for joining us. How about Pittsburgh,
Yes,
Kansas?
hi, thank you.
Treza. Anyone from Pittsburgh? From Ascension Via Christi?
Sandy.
Sandy. How about Ascension Wichita? You guys, Anita on there. Hi, Anita. Great. Oh, you're unmuted. You need to unmute. We can't hear you. You are silent for some reason. No, oh.
No, I think it was just the volume.
I think it was your volume. So if you unmute, Anita, and then crank your volume up a little bit. You were silent.
There we go. Let's try that.
Oh, almost.
Okay, that's my max volume.
There you go. Now we can hear you. Great. Thanks,
Okay.
Anita.
I'm Anita
All right.
Metcalf.
How about
I'm at
Shawnee
Via-
Mission, Advent
I'm
Health?
at Via Christi in Wichita, lymphedema therapy, occupational therapy, cancer rehab.
Very good. Thank you, Anita, for joining. And Advent Health, Shawnee Mission. I feel like I saw someone on, but maybe I didn't. All right. Blue Cross Blue Shield of Kansas City is Dr. Miles with us today. American Cancer Society. All right. Let's go down to anyone who I haven't called yet. So how about anyone from the ECHO Institute in New Mexico? We always invite them to join because we love to have our partners from the ECHO Institute be a active role in how we can continue to provide education outreach across our catchment area to you all. All right. I saw Trish Layton. Trish, are you on? You want to say hi?
Hi, Jen. Hi, everybody. Tricia Layton from Prisma Health Cancer Institute, formerly Greenville Health System, Greenville, South Carolina.
Great. Good to hear you, Trish.
You too.
How about anyone from Bryan Health, Crete Medical? All right. Anyone we haven't introduced yet and you want to say hi? We have a pivot member from our patients engaged in research here at the University of Kansas. Maybe Samantha, are you with us? I think she is, but she may be on mute. All right, if we missed anyone, please say hi, please chime in, or obviously use the chat. So that is part of our community of practice and getting to know each other. As you can see, we have folks from all over the state, and we really appreciate you chiming in. It's a great way for us to get to know each other and for us to hopefully see you, because I know sometimes it's hard to use all these features in the technology, but it is important because we do want to see your face and have you engage in the discussion. As you also heard, we do record this session. We do not record with the cases though. So if you are one of the case presenters or would like to present a case, which we hope you do, you don't have to worry about potentially risking any patient confidentiality because that is not recorded. All right, now we'll cruise up. I think we went backwards, so we will, there we go. All right. So some helpful hints, as we said, we do want to see your face. We want your camera where we can see you. So please don't hesitate to go ahead and come on. We know sometimes people are still in clinic, they're driving. Obviously, we want you to use your best judgment, but we do like to see you so we can obviously have this community where we all get to know each other, even if it starts with a virtual meeting. The other fun part I think we do is these polling questions, and the polls will pop up periodically, and it really helps us to see where we are, what we're all up to, and how we're all integrating some of the tools that we'll talk about tonight. And so what you'll see is a green box, and the green box always is indicative of a poll question. We will pop it up. We'll go ahead and give you some choices. You'll click the box. If you're with a group, you guys can kind of do consensus and answer the best answer. And then we'll see the group responses. And this is our first poll question, so we can kind of test it out and try it. Tracy will go ahead and pop that up. Do you currently use any formal distress screening process for cancer survivors in your organization? And when we talk about cancer survivor, we mean from the time of diagnosis through the lifespan. So go ahead and answer. Oh, I guess I have to answer too. Sorry about that. There we go. Now you can see my answer. All right. And then Tracy will go ahead and pop up our replies. And about 75% of you are using some sort of a formal process, so that's great. I think the important part is that as we talk tonight, we want you to ask questions or engage. We have people who are sort of definitely experts in this area, both from community practice as well as from a hospital and organizational standpoint. And then many of you have some expertise that we would like you to share as well. So I wanted to give you just a quick update as to why we're doing this survivorship series. As we all know, we don't care for cancer patients in a silo. We need to care for them within a community of practice, similar to many of us who are on this session tonight. And so when we think about the cancer survivor sort of being in the middle and we want to engage them in the process, not only does this help, obviously, with their adherence to treatment plans, but also has a direct impact into the success of the therapies that they are being offered and the supportive care that some of our patients need. It's important that we build that community. If you don't have the community built, it's sort of like when you're in clinic and all of a sudden you need to know, how do I get in touch with Clara, or how do I refer someone to Dr. Hamilton? It's really difficult on the fly to have to sort of build that process. So it's important that as we're thinking about our community, that we make sure that we have sort of a good workflow, we know how to get in touch, there's a good feedback loop so we know what's happening with our patients. And I think this visual just kind of helps us understand that. This is another sort of graphic highlighting some of the topics that we're covering as part of this survivorship series. Tonight, obviously, we're focused on psychosocial. You can see sort of some of the other areas that we will cover or have covered or will cover in the future. Last month's session, we covered cardiotoxicity. So if that is an interest to you, please feel free to go to the Masonic Cancer Alliance website where we have that session recorded and you can go back and watch that. The other important part, which I think distress screening feeds nicely into, really has to do with risk stratification. We know that our patients are complicated. You know, they come in the door with comorbid conditions. We know we give them different types of therapy, and we identify what's the greatest risk for our patients. And so I think distress screeners are one more tool that we use in our toolkit to help really risk stratify our patients. So any comments or questions sort of on the goals of what we are trying to accomplish, and anything that, you know, that as you saw sort of the scope of this session that you would like to make sure that we cover, please feel free to use the chat box or unmute yourself and ask any questions or share any anything that you would like to make sure that we cover tonight. It sounds like someone may want to say something, but if not, all right, we will continue on. All right, great. And we're going to start out by having Dr. Hamilton kind of give us an overview and discuss really some definitions and right sizing of distress. So Dr. Hamilton, we'll turn that over to you.
Thanks, Jen. Can you hear me okay?
Perfect. You're
okay, great. I just wanted to make sure before I get started, but as far as distress goes, it's become part of the accreditation process for the Commission on Cancer. That became effective July 1st of 2015, and it's really looking at trying to measure a person's emotional response to the cancer diagnosis, treatment, and throughout the trajectory of their cancer experience. One of the things that is not always thought about is that it's not just the anxiety or depression, but it's the response, the emotional response that they're having to some of their unmet needs as well. And I think it's really important that we point that out tonight because of course we're going to have a response, but a lot of those emotional responses are stemming from something very specific that we need to make sure we're also evaluating.
That's a great point. And as we go to the next slide and you kind of talk about the use of a screener, you know, how does that help you in your daily practice or in the practice of, you know, our cancer care team?
Yeah, so this is the patient needs assessment for the KU Cancer Center. If you look at the very top, we're using the NCCN's distress thermometer scale, which is just an analog scale of 10, 0 to 10, 10 being the most distress, 0 being the least amount of distress. Our step 2, if you can see that, is really looking at these different areas of unmet needs. So we have practical, emotional, substance abuse questions, nutritional questions, and physical health questions. The NCCN has a 37 item list, and we try to consolidate that down to make it a little bit shorter for our patients. And we've gotten some good feedback about that. But really, this section is trying to get at why the patient might be experiencing a significant amount of distress. And then our third step is relatively unique in that it's looking at allowing a patient to self-refer to any supportive care service at our organization.
Sorry, I almost cut you off there. I think that's a really unique, as you said, sort of the unique piece to this screener. But as she'll share some of the data, it's probably one of the most valuable parts of letting patients who maybe don't meet a threshold but still have an interest. And what currently do you kind of coach the team to look at as sort of the cut point or threshold for distress?
Yeah, so on our step 1, anybody who has a score of 6 or higher is supposed to be immediately triaged to some type of supportive care, whichever one ends up being the most appropriate. If you go by the NCCN guidelines or validation of their scale, anybody with a score of 4 or higher is actually experiencing clinically meaningful amounts of distress, which basically means something needs to be done about it. Because it's impacting the quality of life and possibly even the health outcomes associated with that patient's trajectory. So it becomes really important at 4 or higher, but at KU right now, we're triaging at 6 or higher for step 1. With step 2, we're using a triage metric of if any of those 5 domains, somebody indicates 2 out of the 3 being positive, we would triage then. And then obviously with step 3, if anybody self-refers, then we want to make sure that that happens.
And so one thing I think is interesting is that you mentioned that you kind of collapse those categories from the 37 questions of the NCCN tool. And will you give a little just background, because the only part that's validated on the NCCN tool is actually the thermometer. So I think people may worry that if they sort of collapse, that maybe that's not a best practice, but really I think knowing that what's validated and what's not from that screener is really important.
Yeah, absolutely. So as you just said, the only part of the tool that's been validated is the analog scale. The 37 items is actually just a brief inventory that's never been validated. We have done some validity associated with our scale though, and what we have found in ours is that our emotional response questions about anxiety, depression, the amount of weight loss, a substantial amount of weight loss, and then physical pain are the 4 items that are most associated with distress.
Right, that's great. And that's good for us to think about, because a lot of times if we are using this as a risk stratifier, I feel like organizations that use the 37 questions, sometimes they sort of get lost with all of that information. And so it's really important to hone in to the biggest issues or needs for our patients.
I also think that it sometimes causes patient fatigue with filling out surveys. So we want to make sure that we keep in mind that we want to make these scales or these screeners brief for the patient as well.
Absolutely. And I think I want to pause right there and just see if anyone has any questions about that for either you or Clara. And Clara is going to go through the screener that they use at Gilda's as well. But I think because we've sort of talked about the opportunities you have to really consolidate that distress screener, does anyone have any comments or questions that you would like to share at this point?
I do. It's Tricia from Greenville, South Carolina.
Hi, Tricia. Yeah.
Hi. So I'm curious, how did you hone in on those individual items? And just for instance, with regard to the nutrition, and how come you didn't include weight gain as one of the questions with more specifically like the breast cancer patients and how they're prone to weight gain with the AIs and such. How did you get to where you got on those questions?
Yeah, those are great. That's a great question. So we went through a process working with our medical oncology, radiation oncologists, and surgical oncologists, and tried to consolidate some of the things that they felt. Then we worked with our other supportive care services. So we had a team of social workers, a team of dietitians, and we tried to utilize the things that they highlighted on that list of NCCN, the 37 list of items, to consolidate it down to a meaningful 15, as well as looking at the research that was showing which items were the most relevant and most commonly endorsed historically across the literature. After we did that, then we started going to our patient advisory group and kind of honing in on what their thoughts were and getting their feedback. We initially actually included spiritual questions and recently changed those spiritual questions to substance abuse questions because we were recognizing that spirituality, while it's very important in the course of a patient's experience, it didn't necessarily meet an unmet need for most of our patients, where smoking cessation or alcohol abuse or things like that became more of an important thing for them as far as unmet needs go. Related to your question, oh, sorry.
I was just going to ask, as you answered that second part about Trisha's question, maybe allude to the last questions where patients can opt in, and do you find maybe more patients who with weight gain or weight concerns would opt in that section 3?
So that was they always have the option of opting in. I want to make sure that I'm honest and transparent. Right now, the COC is only requiring this to occur at one meaningful time point, at a minimum of one time. And so our institution right now, while we have it implemented to happen one time, this is happening in general towards the beginning of each patient's treatment course. So weight gain, while is a risk factor for breast cancer and our gynecological cancers, it's not a risk factor usually at the beginning, and definitely not throughout the course of the trajectory for the majority of cancers. And so I agree actually with your concern in that that's an area where we could definitely think about trying to make some improvements, but we have changes in weight that definitely need to be addressed in that way, but we aren't looking at it in survivorship so much right now. This is an area where we're hoping to continue to improve, but it's not set at a survivorship time point.
Right. And you do have a pilot, Dr. Hamilton and
Yes.
One of our nurse practitioners, Dr. Rinaldo, has a pilot, and you want to just briefly tell them kind of what you're looking at to see how you would deploy the distress screener in a survivorship clinic. So
Lori's been so kind to continue to implement distress screening in our survivorship clinic. And I would say not just with regards to dietitian, but also looking at pain, fatigue, unmet needs. Each of these criteria actually look substantially different in survivorship than they do at time of diagnosis or at reassessment or any of those time points. When we're talking about going into survivorship, I think that unmet needs look different, and there's a huge world, I would say, of analysis that could be done with distress and unmet needs at survivorship time.
Yep.
I had one quick question. Yeah. In the workflow of administering the distress screener, who responds to it?
Yeah, so at our cancer center right now, what happens is the medical assistants are the people who are giving the patient the paper form, and I think that's really important to note. We're not asking these questions verbally. They're doing it on paper because it improves the validity of their responses. Then the medical assistant is going to input that information into Epic, and then the nurse practitioner or the physician, whoever the appointment is with, addresses the results of the screener with the patient. And at that point in time, they work together in determining what referrals are the most appropriate based off of the screening.
Great. Jody Barr has Dr. Barr has a question. Do you want to read that out?
Dr. Barr said we are also using the distress screen at the time of diagnosis, first EOT visit, and follow-up survivorship visits.
Great.
We're using this as one of our quality measures.
So what Dr. Barr is describing is that, which I think is a really great point, for many of us who have accreditation standards, they use it up front to meet Commission on Cancer accreditation, just like Dr. Hamilton said, but they're also using it as their end of treatment visit or their survivorship visit. And that's a quality metric that we have to have QI projects and so forth for different accreditation standards, including Commission on Cancer. So they have been very active at using some of these improved processes around distress screening, genetics, survivorship to really meet the goals of their accreditation standards. And they are a nice model. And thank you for sharing that, Dr. Barr.
We had another question. Are the forms downloaded in Epic?
So Dr. Hamilton, what happens to your forms once the patient completes them?
When the patient completes the form, they the medical assistant picks it up from them, and then the medical assistant enters the information into the EMR.
And then
Is
what
that
happens
the question?
to your piece of paper after that? Yeah, what happens to that piece of paper?
The piece of paper.
Hello?
Yeah, can you hear me?
It's Stephanie. I'm the one asking the question.
Oh,
okay.
Yeah.
My question is, you said that the papers that are filled out manually, but then the medication aid, what do they put in the computer so the clinician knows what to bring up?
So the EMR actually has the exact same questions overlapping, and so that whatever the patient is endorsing, that's exactly what will be filled out in the EMR.
Okay, so that was my question. Is it part of it in the EMR? Okay, very good. Thanks.
Yeah.
Thanks. Great. Those are great questions. So I think going into that, we'll go back in and see some of the just real quick sort of findings from some of the distress work that Dr. Hamilton's been leading. And here is a summary, we'll start here, of kind of those unmet needs. And do you just want to quickly review this data, and then we'll click through these so that folks know how you're reporting this and how we use it for not only meeting patient needs, but accreditation standards.
Yeah, so what this is just showing us is like a percentage of the number of people who endorsed 1 unmet need, 2 unmet needs, or 3 unmet needs by these different categories. You can see here that spiritual is on here instead of the substance abuse questions because we hadn't changed over. So I just want to make sure I note that. But you can see that like 12% of patients endorsed 1 practical need, and 32 or 4.4% endorsed 2 unmet needs, and that percentage continued to kind of go down. Emotional and our physical needs were of the most common areas where you had 2 or 3 unmet needs endorsed.
Great. And then kind of going through the next slide, hold on a second, there we go, that helped generate referrals. So you want to review that for us?
So basically what we did is we utilized our screeners to help identify these patients that actually needed to be referred. And then this is looking at in the 12 months after the screening, the number of patients that saw each of these different supportive services and the number of appointments that they had. So 227 patients, or 31% of our patients, saw a psychologist, and the number of appointments ranged anywhere from 1 to 7 times in the 12 months after completing the distress screener.
Great. Oh, and then let's go back to that and just see if anyone has any questions about that.
I was going to point out a lot of people are inputting in the chat box how they use their distress screeners, which I think is interesting. People are using them at different time points. So North Kansas City is using it initial visit and pivotal visit, and sometimes the patients fill them out or the nurses and social workers help them. And then Carol Bush points out that a lot of nonprofit organizations and support organizations are integrating screeners as well, which
we will
we'll
hear
more about
momentarily. Yes. All right. Thank you for those comments. And I think that I like North Kansas City using the term pivotal because that's really those high stress times of transition. And so we'll talk a little bit about that too, because I think it's The hard part in standardization is that those transition visits aren't the same if it's a breast patient, a lung patient, a colon patient. So as we try to standardize a process, it often gets difficult because you would like to have sort of one process, but because patients have obviously different sorts of treatment plans and different sort of trajectories, it does make it difficult. So North Kansas City, did you have any comment that you wanted to make on, you know, is that done on an individual basis, or do you really try to do that as a more standard format or workflow? And maybe they're chatting in the chat box. Okay.
I'm trying. Can you hear me?
There you are.
Yes, we can hear you.
I'll let you see. Okay. Sorry, I'm gonna.
Uh-oh.
Hello.
Oh, now we can.
There you go.
So, I'm new to the navigator role here at North Kansas City, but yes, we use the forms. And so I'm sorry, what was the question? I apologize.
Oh, like, is it more done on an individual sort of plan for when they get to the distress screen, or do you have it as a standard workflow?
I think it's primarily after the initial visit. It's based on patients and their needs.
So you do personalize it, and that's really important. You know, so much of what we want to do is personalization, and that does require sort of care coordination and time. So it's good to have different perceptions from different folks. And then I think just before we jump into Clara, sort of giving us a quick overview from Gilda's, Dr. Hamilton, do you just want to briefly talk about a pilot that we're working on with caregivers?
Yeah, so can you hear me now? I feel like I'm...
Clearly. You have to talk a little louder.
Can you hear me now?
Perfect.
Okay, so right now in the caregiver group, we are looking at trying to do a pilot with our bone marrow transplant group. We know that those caregivers are going through a tremendous amount, and there's actually research suggesting that caregivers, no matter the cancer, are going to be going through more distress than patients themselves. So we're hoping that we can evaluate what that experience is for our caregivers and then try to make some interventions for them as well.
That's awesome. And they would be able to potentially use services at Gilda's. So we'll turn this over to Clara to kind of talk a little bit about how you're using distress screening and what you also do for caregivers.
Yeah, so we screen both our patients and our caregivers through our external validated survey that we call Cancer Support Source from our headquarters at Cancer Support Community. So we do it at what we would call our intake, kind of like all of you are talking about, that kind of first visit, covering 15 areas of concern that could be broken down into similar categories that Dr. Hamilton suggested. Ours has, how can we help you? So would you like a staff person to talk to you? Would you like written information? And we have these fact sheets about every level of concern, or no action needed. What happens at the end of them, when we put them in our system, is they get a personalized care report that gives them all of that information, as well as connects them to local resources or national resources that would help address those concerns if they're outside the scope of Gilda's Club's program. So it is very personalized to the patient and to the caregiver, and we can help monitor it. And I think we do talk about rescreening later. So I'll hold kind of our process for that as well in the future. But that's kind of how it works at Gilda's Club. It kind of helps us inform our program and our educational classes if we have several members who are talking about their fears around or concerns about their sleep. We can create a class to address that. So we really use it to inform our program as well as to help personalize our program to each patient and caregiver.
And does this get a feedback loop? So if Dr. Nye has a patient that sees you at Gilda's, does that get back to the provider? How does your feedback loop work?
It doesn't now, but it absolutely could be sent out that way. Our open options is set up that way, but we generally give it to the patient and then they can share it at their leisure to maybe their family members or to their providers as well.
And I wonder, do you ever have any providers that, so if a patient does complete the screener, if they took it back to their care team, could we count this as one of our screeners for our Commission on Cancer?
You could, but to have it count for you, you have to have access to it at every point, and so then it gets into, this is a branded,
Yes.
copyrighted thing, right? This is above my pay grade. But
Yes.
so this is where it gets into talking to our headquarters about hospitals can license them because it does help meet that standard.
Correct. So I think that as people really think about how to grow a program or standardize a program, you have the flexibility to be able to help them do that at these different levels that are above some of our pay grades,
Yes.
as you said, which
Absolutely.
I like that.
We'll put you in touch with someone.
I like it a lot. So let's do another poll question real quick. And if you're using a distress screener in your organization, do you have that repeated time point where you're doing an additional screen, or are you only doing the first screen as they onboard? There you go. No, I'm going to check that just because.
And we can't see what you're clicking.
Oh, you didn't see what I was clicking.
No.
Oh, good.
No,
I was worried
only
everyone
this
was
row
seeing my
can.
answer.
Oh, no. I just assumed what you're doing is
Same
public.
here. So I didn't want you guys to see my answer. These are not, see, these are truly anonymous. So you can answer at your, with confidence. All right, and Tracy will pop up the responses real quick. There we go. So a lot of you are just doing the initial, there's not as much repeat. And I think that's been a real challenge nationally, is to figure out how we do that, when we do that. And like we said, we're trying a pilot in survivorship, but that's a lot of patients when we think about our census. And so these are ongoing struggles that we'll continue to sort of work on. So as we kind of dive just a little deeper in, just remember this was part of risk stratification. You have a very small number of patients who have a high level of need, but if we don't risk stratify, one size fits all is not a good model. We overutilize or underutilize resources. So I think this is a really helpful article, and we will go ahead and, this is not in the toolbox right now, but we'll go ahead and add that because I think it's a great resource just for allocation of how to plan for capacity of the types of needs, as well as some of that data that Dr. Hamilton shared. And as we mentioned, this is part of the Commission on Cancer standards. Dr. Barr mentioned that as well. And it's based off of a lot of the Institutes of Medicine best practices for care management. I did bring this up only because some of you are not familiar with payment models that are currently mainly targeting community practices and Medicare patients. This was a pilot project called the Oncology Care Model. This is actually converting in 2021 to the Oncology First model. And I happen to hear a gentleman who's leading this project from ASCO coordinating with CMS. And this will start in 2021 to impact all of our Medicare patients. So psychosocial distress screening as part of the 13 elements of the IOM will be sort of mandatory regardless if we have an accreditation standard or not. So I just wanted to throw that in as a distress for all of us to add to the fact that not only is this part of accreditation standards, but it is getting more and more integrated into our patient care and how we get paid on the back end. So we will get ready to move on to our cases, but also Gilda's Club has a lot of individual and group work. So I think it's important, as Claire, do you want to kind of just summarize how you determine if patients need more individual or group-based support?
Yeah, it's really obviously.
As we talked about, whether it's metastatic, whether it's a patient with curative intent, you know, feel free to share, chime in, or as we said, please put your favorite resources in the chat box and we'll share those with the group.
Can we put those in the toolkit if they send them to
We
Tracy?
Absolutely put them in the toolkit. The toolkit's growing. We pre-populated it, trying to be efficient for you guys, so please do look at the toolkit and we'll continue to add to it. All right. Well, I think this is another resource for cancer support community. So in summary, you know, I think we talked a lot about the great ways to utilize the stress screening. We have a long way to go though. It's figuring out how to use this and when to use it, and really this appropriate for both the patient and the caregiver. And in wrapping up, we want to thank you all for your participation. Please feel free to chime in or follow up with us as well. Make sure you sign in to the chat box if you haven't. Use your code 81pink to get your continuing education credits. We hope to see you next month. Wednesday, April 8th from 4:30 to 5:30 to talk about cancer rehabilitation, lifestyle modification, kind of diet, exercise, so that whole lifestyle for our patients. And then your toolkit is located on the Masonic Cancer Alliance website. We have a nice little sunflower, just like our logo. Just click on that and reach out to Tracy McCarty if you have any other questions or comments, or of course any of us on the team. So I want to thank our experts tonight, Clara and Dr. Hamilton and Dr. Nye, for joining us, as well as all of our ECHO team and all of you. So if anyone has anything you want to say, please feel free to chime in. Otherwise, we will sign off and we will see you next month on the 8th from 4:30 to 5:30. And have a good rest of your day.
Bye. Bye.